thank you everyone, particularly the Africa Initiative, to putting together the program. It really is inspiring that we give a whole week to this program. And mine is, as the opening one, is going to hit a little bit on the basics of the virus, as was alluded to, as well as somewhat on the programs being put in place to try and control it. You know, one could say we come to this a little bit late in the game, but I'll try to explain why we probably were a little slower getting going than largely due to our experience with the previous outbreak. As with most infectious disease problems, I tend to take a One Health approach. How many, just raise your hands, how many of y'all have heard of One Health? That's nice. It's good to see. I think if we brought this up 2 years, 3 years ago, it would have been substantially smaller, the numbers of persons who had heard the term, which is generally just I think of it as more of an approach to global health problems, particularly those infectious disease global health problems. By the way, can everyone hear me okay?
No, pull the mic closer to you.
I'm not sure. That's
the light.
That's the light. Yeah, that's us.
You could maybe stand a little bit
To the side? I usually don't have that. All right. So, as I said, you're going to hear a fair amount about a One Health approach, and I think it'll be evident pretty quickly why I take a One Health approach to these types of diseases. So first of all, we talk about, there are about 1,500 pathogens that affect the human population. It's bacterial, viral, parasitic. And of those 1,500, about 75% are considered zoonoses. That is, they oftentimes start with in animal populations and are transmitted from those animal populations to human populations. Now, it's worth mentioning that it goes both ways, and many of the bacterial or the human pathogens can be spread into animals as well. In this article shown on your left is from the cover of the Lancet about 2 years ago, and it highlighted those number of zoonoses and highlighted in particular the great number of cases and the substantial cost to various populations. Just as some examples, we talk of that 800 or so, or 1,500 pathogens, roughly, again, about 800 are zoonoses, and of the bacterial, or of those, another 150 are considered emerging infections. So emerging infections have a fairly precise definition. Those bacteria, or those infections that are either newly emerging, newly identified pathogens. And in fact, Ebola is a wonderful example, as highlighted up here on the picture of Scott. That's Scott Dowell at CDC, who was working up the Kikwit outbreak from 1995, and the actual infection had initially been identified in 1976, and at that time it was a brand new virus, so it was kind of a quintessential emerging infection at that time. Now, emerging infections also include those pathogens that are expanding in volume or both geographical location or size of the outbreaks, etc. And so both from the fact that it's a relatively recently identified virus, plus the fact that the epidemiology is greatly shifting, makes it, again, a wonderful example of emerging infections. Many of these are, or these emerging infections are have taken place in the United States before. At present, there's been no case other than the ones we purposely imported of Ebola, but we have had experience with the more recently of first West Nile in the late 1990s, early 2000s. Now, that infection is the single most common vector-borne infection in the United States, and we've had our experience with imported monkeypox. That's a picture of monkeypox here on the bottom left. That was a fairly sizable outbreak that occurred in the presence of importation of Gambian rats, of all things. For some reason, people wanted those as pets. We're also aware of the large outbreak of the SARS, with 8,000 cases, about 800 deaths globally. Several cases were imported into the United States, and then more recently we've been dealing with MERS, the Middle Eastern respiratory syndrome virus. So we do have a fair amount of experience with imported emerging infections, and I think that is reason enough for us to take a fairly thoughtful and aggressive approach to working globally to control the current Ebola outbreak. The Ebola virus itself is a filovirus. It's a negative sense RNA virus. There are 5 strains. Most people don't know that there are that many different versions. Sorry, I'm getting encouraged to speak louder. 5 strains, and all but one is known to be pathogenic to humans. The Reston virus is actually one that's been introduced in the U.S. in monkey populations and doesn't appear to have any pathogenicity for humans. The relevance of the structural proteins and non-structural proteins is generally for the development of products, either therapeutic products or vaccine development. So when we look at the 22 or so outbreaks that have happened in the central African continent, and then more recently, of course, in the Western African outbreak, there are, let's see, they're all listed here in order. Y'all probably can't read it, as I'm seeing they're coming up really small. But I did put an inset of Ebola cases down on the bottom right. And you see that the majority of those outbreaks are occurring in, or have occurred in the Democratic Republic of Congo. Originally, it was called Zaire at the time the outbreak, in 1976, the first outbreak in 1976 took place. You'll see that in total, there's been about, before this last year, about 2,400 cases known. And of those, the mortality rate is about 68%. So we've pretty much doubled that size of the outbreak with just this outbreak, all the cases we've doubled just in this outbreak alone. And we'll talk about a few reasons as to why that's taking place. So when it comes to symptoms, everyone knows probably in the room, has heard through the lay press and through other forms of communication, the very severe manifestations of bleeding and the real story, though, is one of a fairly broad array of symptoms, and I kind of highlighted about when and how those symptoms proceed. The exposure usually happens or the symptoms begin to occur sometime in the first 1 to 2 weeks after exposure. We currently list the far end of the time of exposure, the incubation period of out to 3 weeks. Now, what's important about it is before the onset of symptoms, we don't usually have much of a viral load. The likelihood of spreading the virus in those early times, pre-symptomatic, should make it easier to control, makes the job at least manageable if you can cue in symptoms as opposed to measles, mumps, rubella, etc., where you may be shedding a virus before your symptoms occur. Once you start to have symptoms, that tends to be fairly non-specific. Symptoms can appear to be flu-like illness, fatigue. Then it may seem more typically viral, sore throat. Again, that worsening of the fatigue. And then as you kind of get a week in or so, you can have a GI time, more nausea, vomiting. Really, I think we've learned, I was talking with Mike about this earlier today, we've learned a lot from just the sheer numbers of cases that are occurring. That the GI manifestations, particularly diarrhea, bloody diarrhea, are much more common than we appreciated before. And two, how those severe manifestations may be just as important as contributing to the morbidity and mortality of the disease as the bleeding manifestations, which aren't necessarily manifest in all of the cases. And then as you get into that second week, of course, you're more likely to be either be getting better if you're going to get better, or begin to manifest those bleeding symptoms, which can be quite profound, as most of us have seen on the news. I just showed another slide here on the bottom right, highlighting how the symptoms, manifestations are being communicated to the local populace. This is one of many posters that are being used in the West African education campaigns. Just a few comments about the risks for Ebola. All the cases of human illness or death have occurred in Africa before this outbreak, with the exception of several lab contamination cases. There was one in England and a couple in Russia preceding this outbreak. No cases have been reported naturally occur, or where they've been transmitted, or local transmission in the United States. Of course, we've had the two healthcare workers who were brought over to the sites in Emory, and then more recently in Nebraska. There's a couple of very highest risk patients. One is healthcare workers, for obvious reasons, particularly when you don't know what's going on. People haven't modified their infection control procedures, and as with many new pathogens and infection, novel infections, the healthcare workers tend to take a strong brunt of the morbidity and mortality. And then similarly, the family and friends of patients with Ebola are at great risk. So we've had now reported approaching 6,000 cases. As I said, it's about 2.5 times the number of previous cases in the all preceding outbreaks. We have a total on this graphic total coming up to about 6,000. And you see where Guinea has kind of flattened out, both Sierra Leone and Liberia have been increasing at a rate of doubling each week the number of cases over the last several weeks. And this is just a couple of different graphics that highlight where cases are occurring in West Africa, and then where the overlap of healthcare facilities are in this part of West Africa. And as undoubtedly most people have become aware that we are under, this part of the continent is under supported from its medical health systems, although a number of a large investment in Ebola treatment centers, as well as larger, highly supported programs as well. I found this interesting, and again, Mike was mentioning earlier that this modeling that which first came out towards the end of August. This has some new models that make the worst case scenario with ongoing deterioration. This estimate is on the order of 60,000 cases by the end of the year. The newest calculations seem to be even higher than that, according to Dr. Merson, who's communicated with just today. Now, kind of a best case scenario is if the situation was to dramatically improve, you would see the flattening out of the curve and a total affected population on the order of 10,000, kind of at current rates, which I think most of us consider the best case scenario at the moment, would be another 10 to 15,000 cases over that same time period. So there are some options for therapy that are being considered. Nothing is FDA approved, and truthfully not a lot of organized clinical trials are ongoing. But I think most have heard about ZMapp. ZMapp's a soup of 3 different humanized antibodies put together in a single drug. We know that both at least the first 2 imported cases here were each treated with the ZMapp. The more recent ones brought to Nebraska, there was actually none of that particular drug available. There are a couple of other therapies that are reported as possibly effective and have some animal supporting evidence. One is called favipiravir, which is a Japanese company's product, and it's been shown to protect mice. Then there's a RNA inhibitor, LTAM Ebola, made by, and then BioCryst is another broad antibody compound, both of which have non-human primate data supporting them. There are a couple of, actually there are many candidate vaccines, but the ones that are closest to development are the NIAID, the National Institute for Allergy and Infectious Disease and Immunology. And that just is completing phase 1 trials for those very earliest phases, looking for safety. And that's is exciting, but they're stockpiling some of the vaccine, and we'll be doing some studies in country or in continent, probably at the end of the year or the beginning of next year. And then there's another one called the BSE Ebola virus, which is made from the vesicular stomatitis vaccine background. And both of those versions of vaccine have prevent against lethal infection and non-human primates. So the good news is there are some options out there. The bad news is it's unlikely they're going to have much impact on this study.
I've got a question. Which of those did they use on the 2 Americans? Or did they use any of those?
So the vaccines are not being used yet. They're just being tested for safety. And that's just the GSK one.
You meant the drug, which drug?
Yes.
Yeah, the 2 Americans that were brought that
Yeah,
line.
ZMapp is the one.
ZMapp? Okay. Thank you.
Can we hold questions until the end? Thank you.
I'll get moving here. So this is just, there was a lot of discussion early on whether or not these were unique viruses or they were similarly related to any of the ones that have been around before. And these are data presented from 99 full genomes that were from the Sierra Leone and also from Guinea. And the relatedness of these are shown here. And it is the Ebola Zaire virus, and it is reasonably closely related to some of the earlier strains from the middle part of the 2000 through 2006 lineage. Now, there's been a lot also looking at the different mutations, and while there have been a fairly large number of mutations documented, over 300, the relevance to increasing transmission or in some way changing the likelihood of the virus transmissibility it does not appear to be the case. However, all of those mutations haven't been fully delineated for their function. So we may still hear more on that, but it does not appear to be anything new and different. But rather, it's fairly close to what's been transmitted previously in Central Africa. So I did want to mention that these outbreaks tend to happen in clusters. I probably didn't look at it that closely in that table I had before, but every few years in Central Africa, you see kind of clusters of outbreak. And it wasn't too long after things were really taking off in West Africa at the middle of the summer, early August, when there was an outbreak in the DRC, the Democratic Republic of Congo. And the real interesting thing there is it's a totally separate virus. So this is a unique situation. Most of all the other cases seem to have stemmed from an initial event in the early, beginning in December of last year, when apparently a toddler had an exposure with a bat, which we'll talk a little bit more about in just a minute. And this was a separate outbreak. Both when they looked at the virus, although they're both Ebola Zaire, this is a distinct event in DRC from the one that began in Guinea at the end of last year. So that was comforting in that it wasn't spreading in Central Africa. So how are those two events happening? The initial jump from the animals to from a zoonotic reservoir to the human population. Well, it's believed that their primary reservoir is bats. So again, I'll talk about that in a minute. And then you have the potential for either direct exposure to the bats, direct exposure to a human who's ill, or exposure to a non-human primate, oftentimes a chimpanzee or even a gorilla. Now, why that's relevant, and just as I kind of wrap up my section, is that it has helped to inform our approach to controlling these outbreak events. And so on the left is a map of risk for novel and emerging infections. The red zones are those areas that around the globe where new emerging infections are most likely to occur. And so many of the programs that are identifying new outbreaks, identifying new pathogens, are focused on these areas. So there's a geographical focus, and then there's also the strategic species approach, looking at either high-risk animals such as bats or those who are most closely related to us, the great apes. And so the program we have that's been driven at that is called USAID's Emerging Pandemic Threats Program, and it has several components to it called Predict, Respond, Identify, Prevent, and Prepare. And that kind of is a complete review of all of those strategies. One thing I did want to mention, you won't see anywhere on those early lists of outbreaks of the affected highly vulnerable non-human primates. And we've really had tremendous impact on these populations, particularly those in sanctuary areas, in the case of both gorilla as well as the chimpanzees, and nearly has devastated some of the subpopulations there. And for what it's worth, it has the models of recovery for that, the western gorilla is predicted to be on the order of decades to a full century, the damage to that population. So there's not just humans who are being affected, but extremely vulnerable animals. That has led, of course, that description of when there was ongoing outbreak in the gorilla population, where actually the connection, the gorillas were dying, some human children basically had found a dead chimpanzee, brought it in, and had people exposed, and killed. There was an outbreak of 21, that involved 21 people, most of whom died. And so understanding how things are happening at that human interface is really, really important, and became the grist for David Cronin's Spillover book. I don't know who all's read it, but it's supposed to be a good read. I haven't read it myself. Just a couple more slides here. You have, again, the bat connection. It's just kind of come into acceptability as the reservoir. Bats are really an interesting species. They live in colonies. They are very mobile. Many of the colonies, across different colonies, there's a connection between them, so the ability for it to spread and move is substantial, covers a great geographic range. They also have a huge number of viruses that have been associated with the bat population, in this case the fruit bat. And we even have an expert virus hunter from bats in Lin Fa Long, who's at our Duke US campus as well. He has an affiliation with us as well, and he's looking into many of these issues now. This is just the theory behind how you're going to actually impact these new outbreaks and ideally prevent them. Is you've got the potential for spillover from wildlife into domestic animals into human populations, and the potential for it to move back and forth. But the only way you're really going to have an impact on that is to prevent that initial spillover into the human or into the domestic population, or somehow limit the exposure to humans living close to forest populations or wildlife. But that is harder and harder to control given that you've got habitat loss, extended drought, food insecurity. You've got increased road infrastructure into these areas. You've got ongoing mining, etc. And then you've got the potential of what we found here, and we never really appreciated before. It's not only you have these ecological drivers for the spillover and the opportunities for the viruses or other types of infection to get into the populations, but once it's there, we're seeing so much urbanization, so much globalization. You can now transnavigate the globe in under 24 hours. So the potential for risk for all of us and for things to take off as they have in the West African outbreak was surprising, but in retrospect, really wasn't that surprising. So I'm going to stop there because
Leave that last on the,
that one?
yeah.
Okay.
Okay, so I'm going to follow Chris. Chris is mainly an Ebola expert. So I'm going to tell you what's going on now, how the world is responding to what's happened. I was in Washington last week for a couple of days for another purpose and had a chance to get from the day that President Obama announced the U.S. response. And also some of you may know, and you heard from John, I directed the Global Program on AIDS at WHO, which is probably the last major pandemic we've had since potentially this might be. So I'm sharing a little bit of that experience and try to really want to explain why this is so scary. Could be really scary. Might not be, but could be, and why you hear all the press that you hear, and why the United States has responded the way it has, and why the UN has responded in the way it has in the last few weeks. And so here you see the part of the world that's been most vulnerable in the past to Ebola. But let me go through. You see Chris had a lot more time. But I want to just say what is unique. You need to know what is unique here about this. I'm calling it an epidemic so far, not a pandemic, but why is it so unique? Why are we so worried? Okay, so this is the first time, as you heard from Chris, that Ebola has gotten into urban areas. What you've had are outbreaks, 22 of them since the virus was discovered in 1976. 22 of them in small rural areas. Total number of cases, 2,500. And now what happened is you had this virus get into Monrovia, into Freetown, and into Guinea. And what you have now is an urban outbreak. You don't have a rural outbreak that just dies in a small village. And you have a virus that is spread by bodily fluids. So it's not respiratory. As Chris said, you have to be sick to transmit it, but it still has managed, in this particular case, to spread into urban areas outside local outbreaks. And that is the bottom line fact that has caused this problem to occur. And so if it got, and it's doubling, as you heard, every 3 weeks in numbers in Liberia. I just got an email, and in the next few days, CDC is going to announce a projected 500,000 cases by January. Right now, the world is talking about 6,000. But the projected number, I'm told, is going to be announced by CDC, is 500,000 by January. So it's doubling just every 3 weeks in Nigeria. I think it's probably doubling much faster than that. We don't know the numbers, is part of the problem. These 3 countries have very weak health system infrastructures, and there's no way they could have coped with this virus in their health systems. As you heard from Chris, we have an enormous, at least 200-300 healthcare workers have died from this disease just taking care of their patients. Now, the other problem we had was very delayed action by the international community. Go back and read what the press has been saying. MSF, which is the bravest NGO in the world, trust me, MSF workers have been out screaming for months that something was different. And nobody believed it. Nobody believed it because of what had happened in the previous 22 outbreaks. Okay? So we have two things. We have a spread into urban areas in very poor health systems, and we have no response basically for 8 months from the international community. None occurred. That is just a perfect recipe for what we're facing now. So what are we facing now? Well, when you have a disease, and it was the way it was with AIDS, when there were no antiretroviral drugs, that is presumed to be a death sentence. So 60% of people infected with this virus are dying right now. 60. Okay? So if you get infected, if you think you're going to die by getting infected, you get panic. And when you get panic, you get fear of the disease, you get fear of health workers, you get fear of hospitals. So what do? You stay in your home. You don't come out. You're sick, but you infect all your family members. You infect your friends. You know going to the hospital is probably worse than anything. Okay? And so we're seeing in these 3 countries, now there are a few cases in Nigeria, and on Thursday we're going to actually talk to the man in Nigeria in the lunch hour. We have a session talking to the man in Nigeria who's dealing with the outbreak in Nigeria. Because I can tell you, if this outbreak ever got into the big cities in Nigeria, or in Senegal, or in Togo, or in any of the other major cities in Africa, we would have many more cases very quickly. So we need to keep this disease from getting into urban areas as much as possible, particularly into health systems. Okay? But we also need to get people not to be afraid if they're sick. Because if they're sick and they're not coming out of their homes, they're infecting their families. The other thing that's happened, I'm sure you've read, are the air embargoes. You cannot get a flight to many of these countries right now. If you live in West Africa, you know how you're getting to Europe? You're going across the continent, even braving the Congo forest to get to Kenya or to get to Uganda, to get a plane up north or down south to South Africa. So that this has also complicated the response. We've had an overreaction by airline industry so that you can't get in and out of these countries. So these countries are feeling isolated and their economies are really being devastated. The other thing to point out, and Tony Fauci made this point in Washington last week, almost no research has been done. In 8 months, the data that Chris talked about was not from this outbreak, not from this epidemic. The MSF has had their hands full treating patients. We don't have the natural history. We don't know about transmission. We don't know anything very much about this virus. There has been almost no research done in 8 months on this pandemic, a remarkable consequence of where it has occurred in West Africa. And this has really set us back in trying to understand more about the disease, about the ecology, about transmission in families or in hospitals. We just don't have the data. So there are 22 million at risk in the 3 countries. 22 million in the 3 hardest hit countries. Senegal has some cases and Nigeria has a few cases. The question is, where else is it going to go? Okay, so last week President Obama announced the U.S. Effort to really step up and be the world's leader in dealing with this pandemic or epidemic. And there were 4 things in the plan that was announced. It was all over the media. Controlling the epidemic at its source in West Africa, mitigating second-order impact, economic, social, and political impact, engaging and coordinating with the broader global audience, and fortifying global health security infrastructure in the region and beyond. It's a 4-point plan. It was well reported in the media. You may know that President Obama went to CDC to announce this plan, and it got a tremendous amount of media coverage. Now, in a few words, here's what's going to happen. The U.S. is setting up, it's moving its African command to Monrovia, capital of Liberia. And that is where the U.S. response is going to be centered. Now, why are we using the military? If you look historically, if you look at Haiti, if you look at even New Orleans, if you look at cholera in Africa in the past, if you look at when the Vietnam War was over and we were settling refugees in Guam, it was the only group that could do this, that could mobilize quickly and effectively, was our military. Now, this is an interesting phenomenon because you wouldn't think today you'd send your military with all that's going on in the world right now. you all know what's going on in the world with in the Middle East or Ukraine, but we're sending our military, because there's no one else that can do this, to lead this. And what they're going to do is establish a staging base where they're bringing 3,000 troops with supplies and equipment. We're building 17 Ebola treatment units in Liberia. We're training 500 healthcare workers a week. And we also are going to do a community care campaign in 400,000 households, giving out 50,000 home healthcare kits. Why? Because people are not coming out of their homes. So you can't just set up health facilities. You have to go with this disease to the community and help people deal with the disease in the community. In addition, five other agencies are involved in this response. USAID is sending equipment and supplies. The State Department is going to bring in 100 healthcare workers from the region, other African countries. The CDC is advising universities on what to tell our students, enhancing surveillance and laboratory testing in the United States, and preparing healthcare facilities in this country in case we get Ebola cases. And I can tell you there have been suspect Ebola cases all around the United States right now because of people traveling from West Africa with a fever. As Chris has said, we haven't had any, but you can be sure that U.S. hospitals are on alert for possible Ebola cases. Could it spread in the U.S. healthcare system? Very unlikely. But still, we want to know if there was a case. NIH, as you heard from Chris, is doing vaccine testing. It's a long way. We don't even know what antibody is protective in Ebola. We don't know what protective immunity even means. You probably have read that people are giving blood transfusions from patients that have survived to people that are sick, thinking that there may be antibody. We don't have a clue whether that antibody protects you against disease. In HIV, you get an antibody. Antibody has nothing to do with protecting you against HIV infection. We don't know the basics of Ebola, but NIH is developing a vaccine the best it can. They have done phase 1 trials, as you heard from Chris, in the US, and they are preparing a site in Mali. And actually, they've been working on this site for years in case they ever had to do this. So they're hoping to do a phase 1 trial in Mali within the next few months with this vaccine, as long as it's shown to be safe in the US population. There's no hope for a drug. I think your question is interesting, but we don't know if that drug had any impact on those two individuals, and no one thinks we're going to have a drug that we can offer people. The question is whether transfused blood with antibody in it might be effective, but no one knows. I should say one more thing. There's going to be announced tomorrow the U.S. is signing on to a global health security agenda with many other nations around the world. This has been in the works for a long time. Just so happens, here it is right at the time of Ebola, where we are agreeing to, through this agenda, the United States seeks to accelerate progress to a world safe and secure from infectious disease threats and promote global health security as an international security priority, and to achieve these goals, there will be many of the U.S. Government will be brought in. Health, Human Services, Agriculture, State Defense, and AID, working with 30 other countries around the world on a global health security agenda. Just so happens this has been planned for a while, as I say, but it's occurring at a very good time. And this is going to elevate the field of global health around the security agenda, as we've seen over and over in the past 2 decades. It's the security agenda that often brings resources into global health, and we're going to see this happen again with this new global health security agenda. Okay, now, what about other countries? Sierra Leone, you may have read this weekend, had a shutdown. Sierra Leone shut down the country. Nobody was allowed to leave their home for 3 days. It was a lockdown. They tried to get 30 volunteers to go house to house, and if they did immediate blitz, Sierra Leone has no treatment facilities. And some of you may have heard on NPR this morning that they found 80 dead bodies in homes. 80 dead bodies in the homes of people. So the lockdown had to be done. People are now back on the streets in Sierra Leone. We don't know, again, how many people were infected in those homes. But just to point out why you do house-to-house search is because you know you're going to, unfortunately, find bodies and find sick people. How about the United Nations in general? So the United Nations last week had responded. They appointed a UN systems coordinator. David Nabarro. David Nabarro is the same individual who did the UN coordinated response against avian flu. He's very, very experienced. He comes out of the HIV field. He's from the UK. I know him very, very well. He's very good at this. And he's now been appointed to be the UN systems coordinator for the Ebola outbreak. There's a blueprint and a budget, and at least $1 billion have to be raised, and most of it has already been raised for dealing with this pandemic. On September 18th last week, the Security Council, for the second time in its history, took up a health agenda. First time it took it up was 2001, when it was around the AIDS pandemic. This was the second time that there's ever been a discussion in the Security Council about a disease. And there was a resolution passed which created a new United Nations mission for Ebola emergency response. The details of that are still coming out. They have strongly appealed to the airlines to remove their embargoes and to set up screening of passengers when they come on the planes from West Africa and screening of passengers when they come off the planes from West Africa. Whether the airlines are going to change what their routing schedules, I don't know, but there's been a very strong appeal to the airline industry. The countries that are giving money to the UN response so far, the United States, Canada, France, China, and even Cuba has stepped up because they have a strong presence, as does China, in Africa. The Secretary General announced, and I agree with him, that this is the greatest peacetime challenge that the UN has ever faced in its history. Now, the question I get asked the most, and it's been in the media, is why can't WHO lead and coordinate the global response? In a nutshell, WHO does not have the capabilities. We should stop beating up WHO. The donor community has given up on WHO 20 years ago in terms of the amount of finance support it would give to WHO. WHO has not been able, as an agency, because of its structure, because of its bureaucracy, not because of the people that work there, to be able to deal with crises like this. So when the media, I got a number of media calls, and I tell them the question is irrelevant. WHO can't respond to any major crisis right now. It's not Ebola. It's not a new problem. WHO is not capable of responding to something this big, this quickly. They can provide technical advice, excellent technical advice, but you need the United Nations, you need the military, you need the kind of response that you're seeing now out of the UN out of the United States, and that cannot be done by the World Health Organization. So my last slide talks about what we have to think about. Depends whether we want to be optimistic or pessimistic. But if we talk about what are going to be some of the consequences of this pandemic, you know, the African continent, for those of you who work there, has been doing very well in terms of its economic growth. 6% growth on average for the past decade. This is going to set back certainly the countries that have been infected, and maybe probably other countries around them. West Africa, it's going to take a while for West Africa to recover. Now let's hope it doesn't get to East Africa, Central Africa, and South Africa. But certainly for West Africa, this is a large setback for its economy and development. What's happening is that people with other diseases are basically not being taken care of. So we know you're going to have increased mortality from other causes. The health system is broken. Health workers are dying. So there's no way to go for care. So we know we're going to see increased mortality from other causes. We've already talked about the decimation of the healthcare workforce. The greatest need right now are for healthcare workers from the region, from anywhere. People who want to go and serve, and it's a challenge. It's not without risk, but there's a great need for healthcare workers now. Malnutrition and food insecurity is rising. In some areas, if you read, you can't get food. There's no trade. And so people are starting to see more signs of malnutrition. And of course, lawlessness and loss of state stability. There have been some murders. I think it was in
Guinea.
Which one? In Guinea, yes, in Guinea. There were some murders in Guinea, I can't remember, police or healthcare workers. Healthcare workers.
Journalists and healthcare workers.
Just murdered.
Yeah.
Because the people, oh my God, they're the cause. They're going to bring us Ebola. So you're seeing lawlessness, you're seeing loss of state stability. and it's potentially could get worse. So I'm not a kind of person that sings doom and gloom. I think we're at a very critical point. Okay, we've got, probably we're going to have 500,000 cases, probably 60% will die, then there'll be 300,000 deaths by the end of the year. So the optimistic picture is it doesn't break out of West Africa. The optimistic is it stays in West Africa. Maybe we get a few cases here and there, and it doesn't get much worse than that. The pessimistic picture is that it gets into other urban areas, particularly in Africa, where the health systems are not able to cope, and it spreads very quickly. I don't know which way it's going, but I will tell you that with all the fears we've had about flu, which in some ways is easier to catch, and SARS and MERS, this has the greatest potential for being a worldwide pandemic since the AIDS pandemic. I hope it doesn't happen, but I think that I don't think the response that you've seen is the extraordinary response we've seen in the last week is inappropriate. I think it was entirely appropriate, and I just hope it works. I'll stop here, and Chris and I will be happy to answer
So why don't
questions.
you two sit over in this chair? So I'll go ahead and take your questions.
10% of healthcare workers are being requested. That's not a recruitment technique.
I know. I think the U.S. is trying to supply the equipment that you need to be able to take care of patients. I mean, I have to say, if you talk to people from MSF, they've been very brave, but the health systems are what they are, and I think everything is being done to protect healthcare workers. It's a very difficult setting to work in. I don't know if you've seen the pictures. I understand your point.
Back in the back, Ms. Karen, sir. You, sir.
Yeah, there was an article in the New England Journal of Medicine by Dr. Johnson about Ebola then and now.
Yep.
And I think there's a dynamic between treatment and isolation. And given the fact that there are no treatments, wouldn't it be better just to have isolated so that, in other words, the people who get it will die, but then you will prevent it from spreading? I mean, how would you answer that?
Well, I mean, I don't think there's good evidence that works. I mean, people just, Chris pointed out, it's a 3-week incubation period. I don't know whether you can expect people I don't know that you can identify everybody that needs to be isolated, and I don't know if you can keep them isolated. I know that, I don't know if you've had much experience with this, Chris, but I think most public health people will tell you this is not an effective way to control. Do you know?
Going back to your point earlier, and it's not a good recruiting tool to easily replace the folks who succumbed already. It is a place where I think we are committing some of these resources. We don't really have a huge amount that we're committing to clinical care at this point in time. We are committing a fair number of resources into education, training, and one of the big concerns, because no one really understands, once you get a health system in place to care for Ebola victims, an EVD-based ward and so forth, then theoretically we should do a pretty good job preventing those cases. One of the polls appears to be how people are putting on, that is donning their protective equipment, how they're taking it off.
That's the step.
Is a real
And I will say the history of Ebola is normally as you've gone longer in an outbreak, the mortality comes down because these kind of procedures improve. Remember, a lot of this early death, people didn't know what it was. But I think the isolation, there has been some attempt in cordon sanitaire. I just don't think people feel that will be effective as a way of doing it. And letting people die, that's a tough call. I don't know that you can just let people die. Most people are dying, as Chris said, not from the hemorrging, but from dehydration. And if you can get fluids into them, you have a reasonable chance of saving them.
Sorry, Karen.
I think that's the point.
This gentleman here, Charlotte, and then
Actually, my question follows on from the previous one. I know that because this is now urban rather than rural, I was wondering whether one could predict in best case scenario how long it would take to contain the disease over time, if you're talking about 600,000 people having it, 500,000 by the end of the year, with all the various efforts put in place to contain it or to treat it and so on, how long are we likely is the arc of the disease likely to be? So that's one of my first question. My second is, what has been the role of African healthcare workers in responding to the disease, particularly the Ugandans?
Ugandan?
Yeah, I believe that they've been quite central. I was listening to a Paul Farmer interview on this. Yeah.
I don't know how many other Africans have traveled. You mean how many Africans have
Or
traveled?
what has been the response of the
I don't know. I don't know how many East Africans have gone to West Africa. Do you know?
I know that there was a good number of folks activated from DRC, and then
DRC maybe.
because it was easier to get there. But they had many of them were called back because of their own outbreak.
There's a fear if you go, you may not get back home. You may not. Your country may not let you back in. That's one of the issues I know that's going on right now. That there's a fear of leaving your country because you won't be able to get back into your country. I'm not sure of your first question.
My first question is, in best case scenario, how long can we predict how long it will take to contain this outbreak of Ebola?
Oh, I think there's modeling exercises going
I
on.
showed three levels of what was considered to be kind of the worst case scenario, at least until we heard from Mike just now. It was the worst case scenario, but because it's been doubling at a fairly active rate, that prediction has gotten much worse. Now, if things were to improve, then you're looking at a flattening over the curve and going through a couple of cycles of 21-day periods.
Right. Karen, there are people that model this out with different scenarios. And I think what Chris had on that slide showed you different scenarios. It's impossible to predict. I just got an email from Michelle Berry at Stanford, who's been in touch with CDC, announcing that CDC was the best case, the most likely scenario now was going to be 500,000 cases by January. But I don't think anyone knows for sure. It depends on what happens in the next few months.
But then I'm also assuming that if that's the best case by the end of January, but it's still going to take time for it to taper off.
Oh, sure.
So
Absolutely.
this could go on, this whole outbreak could take
It could
a
go
year.
for years, sure. I think it depends on, it will burn out if it gets into small populations in rural areas. If it's in urban areas, in large healthcare systems, it's not going to burn out.
I mean, there is some good news in all of that. If you look at what's happened with both Senegal and
Nigeria.
They did
So far, Nigeria has been able to, as we'll hear on Thursday, they've done a good job of keeping it contained.
Sir.
Could one consider using the survivors of the epidemic as health workers, or are they?
So that has been done in some cases. You would like to know that they are protected fully. There are people that have survived that have been willing certainly to give their blood and to work. But could I guarantee somebody that they won't get reinfected? I couldn't guarantee them. But I would, if they were willing to, it would be great. I'd still want to put the protective gear on them.
and there's good models for that with the HIV response. There survivors from
Sure.
that.
I would, if anyone wanted to do that, I'd welcome them, but I'd ask them to protect themselves.
Mike, you showed a slide where you talked about what's unique about this outbreak and why we should be worried. And to that slide, I would add another point, which is we should be worried about the evolution of this virus,
Yes.
this RNA virus that has a very high mutation rate. And each transmission event is selective pressure on this virus. I'm wondering what people are talking about in terms of the evolution of this virus.
Mike,
is it moving to be more virulent or less?
So Mike Osterholm had an op-ed piece in the New York Times last week that came out while I was at NIH. NIH was very upset that the Times published that. But what he said is he thinks, I don't know how Chris thinks about this, he said he wasn't too worried about it, but he thinks that the virus could mutate to a respiratory spread. I think that's happened in some species, is that right?
Yeah, so the Reston virus.
The Reston virus.
has been demonstrated to be.
So if this became a respiratory spread, it's a story that's going to be far worse. Now you're talking like a flu, influenza, and that's a totally different epidemic. If that becomes something you cough and it gets in the air and you can infect somebody, So sure, that could happen. Laurie Garrett writes about this all the time, although even she is not thinking this is all that likely. What is your bet on that, Chris?
Well, I mean, one thing that was important was in the documentation of all of those mutation events that accumulated over time. And we know that the longer this goes on, and the more people that are affected, as Charlie said, you know, the opportunity for more impactful mutations is going to be greater. It is as Laurie mentioned in her article, you know, it seems less likely in a virus that's geared for affecting endothelial.
Right. It's less likely because of its pathogenesis, but it would be a totally different picture. We would all have to worry a lot more, and we better have a vaccine by then.
Or it could just become less virulent and then
yes, that's true.
You know, spread to more people.
Yeah,
Maybe
that would
death
be
rate
that would be
lower,
nice.
But then it
Yeah.
becomes a real issue for the world.
Right, and I know
More
there's been
issues.
some speculation whether this virus is more virulent than the previous strain, but most people I've talked to don't think that's the reason why we've had this problem. What do you think?
I think that's definitely, you know, you hit on your slide the issues of urbanization and just the location and the opportunities for getting outside of the confines of the rural area. But I think that that's the most important aspect of it. Will we learn later on that there was actually some accumulation of mutations? It's possible, but I don't think we're going to have.
Now, up till now, there's no evidence it's more virulent. Up till now.
Or transmissible.
Or more transmissible, right. There's no evidence for that. I mean, everybody I've talked to feels it's where it got, not the virus changing, but first time in the history of this virus, it got into where it got, into urban areas.
Sure.
So my question is trying to understand better the transmission methods. Not trained as a microbiologist, not wanting one-word answers of respiratory, etc. What's the potential transmissivity within soil, within water?
Virtually none. It's mostly it's really.
What about in sewage? So you've got raw sewage running around, people, animals running through it.
It might survive, I don't know. It survives on a desk. The virus, they've done some survival studies.
Yeah, but it's not, you know, these are not real, you know, outside of obviously contaminated samples, bloody samples, etc.
You'd have
So
to have
in blood,
I mean, yeah, you could. I'm
but
not
what
saying
about
no.
in feces? In other words, people handling the bodies, are they only
Yes.
need to be concerned about blood? Or
No,
they need to be
anybody
concerned about
knows.
feces?
Any body
Any body fluid. In fact, we know a lot of people have gotten contaminated in burials. We know that burials have played a role because when you bury the dead, you know, you wash the dead and you clean the dead.
ritualistic.
And when you have
the
the
rituals
dead-
around burials, we know have caused problems.
And so these people also are vomiting, diarrhea.
That's all.
So everybody feels that that's not a contamination
No,
method.
that is.
Okay,
Sure,
so
but the
feces,
duration with which it's liable to be.
a day, a year.
It's an enveloped virus, it doesn't last long.
Right.
So,
See,
a
now,
day.
you were referring to sewage. I thought you meant sewage, you know, in a sewage plant or sewage.
No.
You mean if people have
Raw
vomited
sewage.
stool? Yeah, no, that's all. If it's coming out of them, that's all.
So that's running down the street, that's in the back of the house.
It doesn't survive long.
Mhm.
It's an enveloped virus, the lipid bilayer flakes off as soon as it gets
Right.
exposed to soaps or detergents or anything
I'm not
like that.
talking now, just
And I know
saying.
in environmental surfaces, it won't last long.
It won't last long. It's not the majority of spread. Majority of spread is on your hands, saliva, blood, vomit, as you take care of a patient, as you take care of your family member. That's the main spread.
Charlie, and then, I'm sorry, and then a question back here.
Why, if it comes from bats, haven't we had outbreaks earlier in West Africa? All these human populations are intimate with bats. They
They've
eat them,
actually
they carry
gone-
them, they kill them.
Well, how
all
about
the time.
I heard that there were many more bats now because of the deforestation, and that the bat population, I read an article about this, has greatly increased, Charlie. I have no idea if that's true. I'm not a Batman, but I have read that that's played a role. And I've also read that it was probably more eating the bush meat that the bats, as Chris was saying, that probably plays a role more than direct bat infection.
They eat the bats all over there. The kids,
Yeah,
Yeah, they eat
that
them
eats the bats too, right?
Now, over time, there's likely been, they've been done several surveys in the bats over the last 10 to 15 years, I mean, beyond that, earlier than that, but mostly in and around West Africa, et cetera. Now, or East Africa.
But probably, this hasn't been well studied.
No, but there are several studies that have documented rates as high as 15%.
No, but why if it's worse now? I mean, whether the rates are higher now with that.
Well, that gets back to the point about changing ecology that you were just emphasizing, and you in that period of time you drastically challenged the environment, both through an increased logging, road.
A lot of deforestation, Charlie. That's the speculation.
So I have 4 questions on the dock, 1, 2, 3, 4, back here first.
Thanks. So I just want to make quick comments, and then Mike, I got a question for you. So one of the issues with regard to the survivors in the healthcare is the government policy. So in Liberia, once a person...
Yeah, you know Liberia. You should talk about it.
But so in Liberia, the way the government is handling it is that if you have a known contact, then you're decommissioned from providing care for a period of 21 days. Now, after that time point, you can be reinstated, but often if you are known to have had the symptoms or you have a family member, often people won't come to you for care. There's lots of beliefs around kind of spiritual positioning and other things. And so in many cases, most of the government health systems are not going to have somebody who's survived or even exposed be back in the system, which is leading to total decay of services. And with regard to kind of the burial question, this is a major economic drain. So many of the men that provide the funeral services and manage the bodies are charging up to $800 a burial, which is 4 times the annual salaries. So not only can they not get food, but to perform these appropriate rites, they're having to take out loans and pay a huge amount of money.
That's interesting. It's very interesting.
Which is hugely problematic. And in terms of the Uganda situation, most of that is in an advisory role. So there's very few Ugandans that are actually providing direct care. So I'm working with the mental health program out of the Carter Center, and so we have a Ugandan psychiatrist who's doing advising, but no direct contact, which I think is by her choice and probably a smart move. So the question I wanted to ask is about parallel systems, which I think is a historical problem and now is being reinforced. So one of the problems is that you have MSF doing their services, and in Liberia, all of these medical missions throughout the country, and a very weak central health system. And as of September 1st, the Liberian government had only received $300,000 in response to this. While there are hundreds of thousands and millions being raised, none of that is going to the government health systems. And so what's happening is these things are rapidly decaying, people can't provide services, and then these other processes are being built as parallel. So I'm wondering, with Obama's statement and these plans, is any of that going to be health systems strengthening, or is it going to be more parallel systems?
Right. So my gut feeling, it's just the way the U.S. government tends to work. They're going to set up these 17 hospitals, and they're going to have trained people to work in them, and you'll have another parallel system. I can't think that anyone right now is going to put as a top priority strengthening the health systems of these 3 countries. I will tell you that we had long discussions in Washington about the so-called recovery period and what should be done to do that. And the president of Liberia wrote a letter to Obama pleading for help, and I don't know if she got the help she wanted, 3,000 U.S. troops. She might have preferred her own health system to be strengthened, but I do think that I'm hopeful that what you're saying will happen. There's certainly great sensitivity to that in the United States, that the ultimate solution to this is not more parallel systems. Now, if you've seen MSF and Partners in Health, they've done a really good job of trying to raise millions of dollars for their own health system right now, their own hospitals. I can't be critical of that. Right now, given the status of things, maybe we need parallel systems, but we do need in the end, soon, hopefully, once this is contained, to deal with what you're saying. Because we need to strengthen these health systems in West Africa if they're going to be able to cope with these kind of problems. I fully agree with you.
You said that the people who contracted the Ebola and survived, they could possibly be health workers who would be protected. you also said that there were people who had the disease that people didn't know about. How do we know the disease is not becoming endemic in the population, and there are people who've had the disease, they didn't show all the symptoms, but they could possibly be spreading the disease, and that these people could bring it here? And there was a similar situation back in the 70s with the Lassa, when the Lassa fever, they thought it was deadly, but then they found out sections of the population had it in their blood, and some of them could pass it. How do we know that the Ebola is not becoming endemic in the population, and people may have it, can pass it, not show the symptoms?
Usually the one area of residual viral persistence is, which is most often talked about, where it can go into the asymptomatic time, is semen. And that can remain with detectable virus for months. And that's been shown in a number of different studies.
But you understand you transmit only when you're sick.
What about the semen? He was saying.
Except for semen. That's
the one
exception.
residual.
That's the only residual.
So do you hold them in beyond the 21 days?
We
I don't think that
encourage
would-
we encourage a behavioral change.
That's a larger issue.
Question here. Wanted to ask, so we know bats are most likely the reservoir for this, and as we know, bats are also reservoirs for rabies, Hendra, many more.
SARS. No, not SARs.
No, SARS is
SARS.
not the
SARS,
Nipah.
So my question is like, obviously the bats are not being affected. Is there any research going on, like why bats are not affected by any of these?
Good question.
Yeah, actually, it's this is where Lin Fa Wang, who I mentioned before.
We need to know the reason for that.
Yeah, he's studying it. They've got bats have a very unique immune system, very tolerant to viruses. They can have any number of viruses be viremic at any time. And we also know that the more stressed they become, the higher their viremias become, which may be some of that, as your point earlier about why that may put the stress on the bats due to their changing environments, et cetera, may actually increase the likelihood of passage of some of these.
We really have the world authority. The picture that Chris showed of Lin Fa Wang, he really is the Batman on this problem. And his lab in Singapore.
He has a huge grant from the Singaporean government to actually study just this question, the immune tolerance.
So here's a factoid: 1/6 of all mammals are bats.
Wow.
Another very quick, if that's all right. My next question is, so actually touching on what Charlie Nann's question was, is there a possibility, so we know that the virus has mutated. Now, do you think, is it possible that the virus may be trying to adapt and actually the morbidity might go down as it adapts more to the human immune system?
Well, that's typically the direction we think of things as becoming more tolerant.
Be nice.
Over time. It would be nice in some ways, but if it does become less virulent, as someone was mentioning before, the potential for having a disease that is then milder and less
recognizable. You pay a price for less virulence, right?
Yes.
You'd be less sick. Then you're going to get into a situation where you might be transmitting but not sick.
Just one last question. So what is the effect? So we know that so many $1 million are going into research into controlling this outbreak, which is obviously a very good thing because it has the potential of becoming the next big pandemic. But considering this is West Africa, what is the impact it's having on other diseases, especially diseases which we're trying to really control, like the health system in general? Like the resources are, so obviously the resources have to come from somewhere. So if you have like, this is the set of resources, that's going, obviously
I mentioned that there's great concern that other diseases are being neglected because there's no healthcare system, not enough of a healthcare system to deal with it, and we might see rising mortality from other diseases that were coming under control. What is an interesting question is what to do about malaria. David Nabarro, in a press conference, the UN coordinator, was asked about malaria because a lot of people who present with fever, is it Ebola or is it malaria? And I don't know if he's going to do this, but he's recommending that everybody be treated for malaria. And then first. and then if they don't get better, you can screen them for Ebola. I'm not so sure that'll work, but there's a real interesting problem. You're mentioning a really potential consequence of Ebola. Okay?
So a question here in front and then back there.
Comment and question. Comment for the group. If you want to know more about the Army's involvement in Ebola, read The Hot Zone and read about their containment operation they did in Western Virginia with arresting Ebola and the CDC. Very good book. Highly recommended. Also, the second order effect, one of you touched on, is the stability situation that National Command Authority is looking at very closely. You don't have to work game this out too far to figure out what could happen in West Africa of all civil and social services breakdown.
Are you in the military?
I am. I got to talk to you after this. So the question I had was, talk about the burials and how they catch the disease. What other cultural behaviors help you catch the disease? Are you aware of any?
Any other cultural issues?
Well, I mean, I think the cultural issues aren't as much about transmission as they are the broader control problems, because there's so much spirit belief and contagion issues. We've been, I mean, it's sadly ironic. We've been spending all this time working on epilepsy to tell people that it's not contagious through saliva, blood, through feces. They think that many diseases are transmitted through passing gas in some cases. So many neurological and psychiatric disorders are highly, highly stigmatized. So we do all these campaigns about that. Now we have this disorder that's transmitted the way that they often assumed that spirit transmission and sense spirits work. So I think it's not as, I mean, in some ways that's a positive from a disease control, but it's awful from a psychosocial and overall well-being of the health workers and for the families. But to be honest, I don't think it's like Kuru or some of these prion diseases where there's certain cultural practices that lead to, you know.
That's good to know, because as we map the human terrain, as we deploy forces forward, we need to know all that so we can train our forces accordingly.
Well, let me just add here, Uganda, although it was a much smaller outbreak, was successful in changing so-called cultural practices regarding burial. All it took was a very calm sort of interaction between healthcare providers and community people who bury people, and talking about, this is the way you need to protect. We need to bury people right away. We can't have a 24-hour vigil, right? We need to minimize the amount of people around the burial. That happened very easily. As long as people were respected, you weren't putting them down for some sort of crazy cultural ritual. But you said, this is the way we need to change it. This is a moment of crisis. Let's change the way in which we bury our people. It was very successful.
So we have time for one more question back here.
I just wanted, how close are we to a test that would identify a patient as being exposed? In other words, if you had somebody with a fever in a situation, to a test. In other words, any kind of, you know, IgM or viral or...
Well, the diagnostics are fairly straightforward, actually. They're good. The diagnostics are fairly straightforward for this, and you have very high levels of viremia. Again, you're usually symptomatic there, but the symptoms can be indistinguishable.
Right.
Exposed.
Well, that's to tell if you're if you're actively infected and symptomatically infected. And again,
but exposed, I don't think.
But for early phase stuff, actually, it's an area of great interest of ours here in our research group. We actually look at other parts of the immune response, the host response to viruses, similar viruses, and we've refined a lot of these approaches for different diseases. There actually is some interesting recent data on Ebola itself, and actually being able to potentially detect an infection pre-symptomatically. No, that's not near the standpoint of implementation in the next several years, but it's an interesting approach to your question that may have a future application.
So despite being around more than 40 years, we have very little knowledge about many of the questions, the research questions you're asking. It's just a virus that we didn't put time into. You know, we didn't put money and time into. We could have had a vaccine by now if we ever thought this would have been the case.
So on that glum note, I will close with thanks to the Duke Center for International Studies and Rob Sikorsky, who helped put this together, Duke Global Health Institute under Mike Merson, the Duke Africa Initiative, represented here by Charlie Pio, and the program in the Arts of the Moving Image. And we're going to be having events at 5 p.m. Tuesday, Wednesday, and Friday, including a free screening of Contagion if you really want to get hysterical and worried. And please stay for food and conversations. Thank you.